Hello, microbiologists. We are going to talk about the respiratory system and diseases of the respiratory system. So we are breaking these down into upper respiratory and lower respiratory. So let's talk through that for a second. Okay, so the upper respiratory, this is going to be the upper respiratory, like your nose, your sinuses back here, your nasal cavity, all that, the auditory tubes that equalize pressure, your tonsils, all those things. That's going to be your upper respiratory, your lower, your trachea and down, your bronchi, your alveoli, your lungs, right? Okay, so upper and lower. Structures of the lower respiratory system. Basically and essentially, we are talking about your lungs. When we're talking about lower respiratory, we are primarily talking about your lungs. So I'm just throwing that out there that we are primarily trying to adjust this so you can see a little better. Okay, there we go. Your lungs expanding and contracting, and in there you have bronchioles, which are attached to your alveoli cells that contract and go snap back together like elastic, and in those you have some protections, right? You do have protecting components. You have some ciliary in your, right, that moves the air down. You have some little cilia there, and you have some alveolar macrophages that devour microorganisms. So you do have some macrophages in your lungs to try and keep microbes out. Obviously, you do not want microbes in your lungs. You probably knew that before this class. Okay. Again, looking again at the respiratory system. So your upper, right? Here's your upper, really from your neck up, starting with your epiglottis, larynx, trachea, all that down is your lower respiratory system. We're going to talk a little bit about this, but upper respiratory, this is primarily going to be your sinuses, your ear infections, your middle ear, those kinds of things. Lower respiratory system, obviously going to be a little bit more detrimental, mostly talking about pneumonia. And here's your alveoli cells, right? This is, do you remember, if you remember what this looks like, here's your bronchial tubes, your alveolar sac, and then there's going to be these little macrophages in there that are there to kill any bacteria. Now, their microorganisms are not typically present. You do not have like a lung microbiome naturally. No, you do not want microbes in your lungs. Bad. No, you don't want that. When there's microbes in your lungs, you usually have a disease. The upper respiratory system, however, is colonized by many microorganisms. Think of all the like snotty, gooey things that you have in your snot, your eye, right? There's a lot of goo. And they have a natural microbiome. There's a normal microbiome that limits growth of pathogens. However, sometimes even those normal microbes, those normal microbiome that you have in your upper respiratory, those become sort of opportunistic depending on if you get sick from something else. Sometimes they can override. So first question, why do patients with methicillin-resistant Staphylococcus aureus, so MRSA, as part of their normal nasal microbiota, right? So it's normally in your microbiota that you have some Staph aureus, right? But it is resistant to methicillin, the psyllins, essentially. Why would that be bad if you were in a hospital? Like, why would your normal, that's like normally in your snot, what's the big deal? You can pause it and guess, or I will just tell you. Your nasal secretions that contain this can actually contaminate the equipment, the breathing. Think how often you're breathing in a very contained hospital room. So it can contaminate that equipment. It can contaminate person. You know, you can breathe on the nurse and then the nurse can go somewhere else. And that bacteria can establish an infection in a wound in another patient. This is why there's so much scrubbing and changing things out. Or a person who has a low resistance, right? If you're in the hospital, you're not in peak condition. Otherwise, you wouldn't be in the hospital. So your normal MRSA can contaminate equipment or people, you know, if you're a nurse or something, that's why you're constantly sterilizing yourself. Sometimes it's the Staph aureus that is resistant coming from someone else's like nasal, or just they sneeze or they breathe on you. And it's really difficult to treat if you have that and it becomes infected in someone else. So that's kind of a big deal. Okay, let's talk about streptococcal respiratory diseases. Sore throats. This is pretty common, right? You've had a sore throat probably at least once in your life. Laryngitis, bronchitis, scarlet fever, pneumatic fever, all kinds of great streptococcal respiratory diseases, making you with a sore throat or strep throat. Disease depends on the virulent factors present, occurs when normal microbiota are depleted, new is introduced, or your adaptive immunity is sometimes impaired, and this is when your streptococcal goes crazy. Spread via respiratory droplets occurs most often in the winter and spring when you're ironically had a sneezing fit, which usually occurs in the winter and the spring, just when everyone is in close contact with each other. And of course, they're giving people penicillin, everyone except for me and those of us who are allergic to penicillin, and we just have to suck it up. So here's some common manifestations of respiratory disease. You have the common cold, you have the flu, you have strep throat, you have pneumonia, viral and bacterial. There's a bunch of flavors of pneumonia. We will tell you what they are. Bronchitis, anthrax. You're probably not going to get anthrax. You're probably not going to just happen to get anthrax. And then there's, of course, your friends, the coronavirus that we are all familiar with. Yes. Okay. Let's start out strong with some diphtheria. Right, so this is sore throat, localized fever, pain, presence of pseudomembrane that construct airway. Let me show you a picture of that. So basically this is the pseudomembrane, and it's like, you can see that this would not be great, right? You're not going to be able to swallow, you're not going to be able to breathe. Nobody wants that. And that is the main, really, sign, symptom, virulent factor of diphtheria. You're going to get that in your throat. You're not going to be able to breathe properly, and you're not going to be able to eat very well. It's caused by C. diphtheriae, and it produces the diphtheria toxin and prevents polypeptide synthesis. Here's what it looks like. Little diphtheria under the microscope. So essentially we have our diphtheria toxin. It binds to an outside the membrane, right? And then it gets, what does it get? Endocytosed, right? We're endocytosing that thing, eating it, kind of, cell eating. Then it's just an endocytotic vessel just hanging out here. What could possibly go wrong? Well, let me tell you what could go wrong. This produces a sort of a subunit. We're calling it a subunit that completely prevents mRNA transcription in the nucleus of a human cell. You can imagine that's not good, right? Transcription, pretty important. All of that is pretty important. So this is diphtheria and different reasons why you do not want diphtheria. It's spread via respiratory droplets. Most of the things happening in your respiratory system is going to be spread by respiratory droplets. It is the leading cause of death among unimmunized children. So especially also the immunocompromised. So there is a diagnosis based on the ELK test that very quickly tells you whether you have diphtheria. It's treated with antibiotics, and immunization is a pretty effective treatment. So I highly recommend the diphtheria vaccine. Rhinosinusitis. Otis media is basically results in severe pain in the ears. So this is going to be your good times ear infection. Very common among children, just very common among people that have like a lot of things going on up here. Damage to upper respiratory system and auditory tube. So essentially, let's take an anatomy and physiology walk. Here is your upper respiratory ear canal, right? So here's your external ear canal. You should have a tympanic membrane or an eardrum here. Here's what happens. Your eustachian tube, your middle ear, all of this gets infected. It pushes up against your eardrum and your ear canal, causing pain. This whole area causes pain. Sometimes you will see that it presents as a tooth, as like a back toothache. People will call their dentist in a panic going, oh my gosh, there's something wrong with my teeth. And they'll be like, actually, you have an ear infection that just feels like, because it's coming from this part. It's actually your ear and your sinuses that are pushing against your tooth. So the middle ear is infected via these auditory tubes. When it's real common, what you will get if you have tubes in your ears, you had a little tube here in your tympanic membrane that actually lets this drain so it doesn't build up there and get all gross, right? So sometimes in kids, this just isn't growing properly. It's clogging this area up. So they'll put like a little tube. It's like a little plastic tube right here. So it'll drain out the ears so that they don't keep getting middle ear infections. Again, it's very common in children. In adults, you have an ear infection. So one of the ways people will talk about the rhinosinusitis is your nose, right? And you have just like a nasal infection, and nasal flushing can reduce the duration of the symptoms. It's a little bit disgusting, but it does kind of keep that. Again, up here, we're doing the same thing. The ear infection, we're draining it with a tube. Here, we're doing the same thing. We're just flushing it out so that it doesn't just sit there and multiply and gross.